Welcome to Fellowship Safaris, conversations about people of color and their journeys to subspecialist training in their countries of origin and around the world. Hi everyone and welcome to Fellowship Safaris. My name is Njeri. Today, I am really excited to have the next guest, who is a new colleague and friend, and actually my first East African guest of this show. And I'll give him an opportunity to introduce himself and give his professional qualifications.
Hi, everybody. My name is Francis Furia. I am a pediatrician, and I'm both adult and pediatric nephrologist. And I'm also an associate professor of pediatrics.
That is fantastic to hear, Francis. I know you've mentioned nephrology. Is there any other subspecialty that you're subspecialized in?
Yes. I do adult and pediatric nephrology as well as pediatric rheumatology.
Fantastic. And of course, my curiosity is already piqued because these are two subspecialties, and we'll get to that in a moment. However, I want to start by asking, what drew you to pediatrics? Why did you pick it as a specialty?
Well, it's quite interesting that pediatrics wasn't my first choice, so to speak. But I would like to say that I liked everything in medicine. I mean, during my training, and actually my favorite study was development studies, which is not even linked to medicine. But I liked all the disciplines in medicine. So when it came to making choices, what I should specialize into, it is a little bit difficult. My very first choice was internal medicine, and my second choice was general surgery. For some reasons, I did not get accepted to pursue internal medicine, and I was picked for my second choice, which is general surgery. And of course, when I enrolled into the residence program, I switched to pediatrics. So that's how I ended up in pediatrics.
Oh, wow. That is such an interesting trajectory. So, if this conversation had gone a bit differently a few years ago, you'd be a surgeon right now.
Certainly.
So, once you completed doing pediatrics, what made you start thinking about subspecialization?
I think one of the reasons is the fact that we had very few subspecialists in Tanzania. And I think that drew me into that. And of course, that was partly during my residence. Some of the care, subspecialized care of some of our patients was quite challenging. And at times we had to rely to adult physicians who were not able to really give us the support that we needed. So because of that, I applied for subspecialty before even completing my training. And what is interesting again is I did not pick nephrology on the outset. I picked neurology.
That's so interesting when you first mentioned that. So how did you get from you picked neurology and then the path is on nephrology? Walk us through that.
So, well, I enrolled for neurology, but then I changed my mind. I said, I think I should go for nephrology. So I switched to nephrology. And this was basically adult nephrology. And actually, I applied before finishing my residence. I completed my residence in pediatrics in August. And in November, early November, I joined the subspecialty training.
I've heard you mentioning you went to do adult nephrology. Why is it that it was adult nephrology and not pediatric nephrology?
All right. So, first of all, we did not have training programs in Tanzania, and this was a new program which had been established 3 years earlier when I joined the program. And this program was established with international collaboration, and it was supposed to be a sandwich program that some of the studies will be conducted in Tanzania, others will be pursued in India and in Bergen, Norway. And for that to happen, for some reasons, the university made joining requirements to be friendly to both candidates that have pursued pediatrics or internal medicine training.
And for this particular program that was starting up, which I think from like that sort of international view where you have some training in Tanzania, some in India, and some in Norway, How was the funding structure going to be for that particular program? Was it sponsored or was there a requirement for you to pay a certain amount?
So luckily for us, the program was sponsoring candidates, and it was covering for all the expenses, including traveling expenses to and fro India and back in Norway, as well as the living cost when we are doing the training, and the fees and everything was paid for that program.
And how was that experience for you studying in three different countries and three different continents?
So first of all is being a pediatrician, I joined the nephrology program. And in our institute, we did not have well developed subspecialty services in nephrology. I guess that's one of the reasons that it had to be designed with sandwich nature so that we can accommodate exposure to services that are not offered in the country. So initially, I was kind of not sure what it entails because being a pediatrician and joining a program which is offered under the Department of Internal Medicine. It was a little bit intriguing joining the program as a pediatrician and hosted in the Department of Internal Medicine. Now I have to see adults. And I wasn't really sure what is going on in the other setting. So when I went to India, that's when I noted that there's a similar program in India that is accommodating both pediatricians as well as internal medicine physicians to join subspecialty program. And this included nephrology, cardiology, neurology, which was interesting for that matter. And then the other thing that is also interesting is the fact that I trained in three continents in three different settings. So if you look at the setting in Tanzania and the setting in India, you will see that Tanzania is really developing and India is a mixture, it's a hybrid between developing and developed countries because they had everything that you could find in the developed world, but they are providing services in the spirit of limited resource setting. And if you go to Norway, they had everything. So, I mean, these three settings gave me an exposure of three different worlds when you look at the healthcare delivery.
That's so interesting that you can mention the different settings where one was straight up resource limited, then hybrid, and then now state of the art. I like, what you've written on Instagram, mwanafunzi wa maisha, a student of life. What was that experience for you as a student having to adjust to all these different kind of settings?
First of all, I'm lucky because I'm quite open. So there's change in culture. There's a change in food. The weather wasn't really bad. I was lucky. I went to Norway during summer and I went to India during what they call winter. So it wasn't the time that it was really hot. So I did not really struggle on that. But the interaction that you have with people, here you have people that are speaking Norwegian with very minimal English. But then I had very good professors that were really kind with me, allowed me to sit in their clinic. We would discuss patients and they would give me permission to examine patients and to do assessment, including ultrasound, which was really kind of them. And then in India, what was interesting in India is the fact that I was training in an institution which was receiving patients that were speaking different Indian languages. So, which was an advantage for me, basically. So we were supposed to use Hindu, Malayan, Tamil, and all these languages. And so even the residents that were training in nephrology in India could not speak all the languages. So we had the luxury of having interpreters that were sitting with us. So that made my life easy because, well, I don't speak all these languages, but then I had an interpreter. And the colleagues that were training there could not speak all the languages. So they also made use of the interpreters. So it kind of helped because we are all in the same kind of setting.
Oh, that's really interesting to just hear about some of the things that you needed to sort of get used to. And it's helpful to hear that your flexibility helped you adjust no matter the situation. And what was the most impactful in terms of skills that you acquired in the nephrology training overall in the 2 years?
Yeah, so when I started the training, my hospital that was teaching hospital did not have dedicated nephrology services. There was no nephrology unit. There was only a nephrology clinic. And in India, there was a huge department of nephrology, which was, if you're looking at the workload, these guys were doing almost 30 kidney biopsies in a week. But then when I went to Norway, the difference between Norway and India is a lot of patients. When we are sitting in clinic at India, we used to see 150 patients in one clinic. And the clinic will run from sometimes 10 a.m. to at times 7, 8 p.m. And these clinics are running through that time and seeing 150 patients. But if you go to Norway, my professors, when they had 3 patients, that would have been called a very busy day. And they will be having one patient coming in at 8:30, the second patient coming in at 9:15, and the last patient walking in at 11. But they will tell you that today I have a very busy day, and it's only 3 patients. So you could see the contrast of what is happening. So that was really interesting. And when I come back home, with the fact that we do not have so many things going on, I got an opportunity to start things going and improving the care that was given back home.
And when it came to coming home to start out a program, you mentioned earlier it was initially just one clinic. So was it an easy transition coming back and starting up a service? Were you the
So
only nephrologist at the time?
no, I was. So I at the time when I was starting, there were 2 nephrologists and 1 in training. I was the 4th nephrologist. The difference is that I was a pediatrician. I was the first pediatrician to train in nephrology. So when I came back, I had to work in 2 departments. I was working in the pediatric department, but at the same time, because I'm a nephrologist, I was working in the other nephrology unit. So I
Oh,
was
wow.
splitting my time. And at that time, of course, I got appointed to the university position when I was
Mhm.
in training. So I
Oh,
had
wow. Mhm.
a teaching position, but then I was working in the teaching hospital in adult nephrology as well in pediatrics.
Wait, so Tanzania is a big country. So there were only 4 nephrologists for what was the population at that time, if you have a rough estimate?
That would have been more than 55 million I believe.
What? So
And
for
that
a
was
55 million population, there were only 4 nephrologists for all of Tanzania.
yes, and that is not long ago. It was 13 years ago.
Oh, wow. And I think it blows my mind because as a pediatrician, seeing adults for me can get so overwhelming because when I subspecialized, I really wanted to focus on everyone who's under the age of 21. And so to hear you saying that you are running both a pediatric and an adult clinic, I think for a lot of pediatricians out there, if they had to also take care of adults, that would have been very, very tough.
Yes, indeed. And actually, so what I'm saying, when I came back, there was an adult nephrology clinic. There was no pediatric services at all for nephrology. So if we needed help, we would call in the adult physicians. And you could imagine calling in an adult physician, asking them to help you with a patient that is premature baby, with 1.5 kilogram. And you're asking them to help you manage this child who might be having acute kidney injury. Just imagine how would the face of the adult physician would be like. So,
Oh,
so that
wow.
was the challenge that we used to have.
Yes.
So when I came back, I was working with adults. I thought that it is going to be really difficult if I just work with adults. So I requested to establish a pediatric nephrology clinic. And at the same time, I established some other services that were not there.
And when it came to the various, equipment and things that you needed, were your hospitals able to get those equipments, or did you have to be innovative with some of the services, like PD catheters and, these fluids that are usually used during, dialysis and that sort of thing? Did the hospitals have this equipment, or how did you go about this particular situation?
So the very first patients that I did PD on, I improvised. Everything was improvised. And I was fortunate enough that I read a case report on the internet, and that case report really showed me how to improvise. And I did improvise for my first 2 cases that I did for the first time. But I was quite happy that the patient was very, very polite and kind to let me help the baby. And also the other staff were really willing to learn, you know. And we did that. And of course, it was a case report that was published later, but that was the first dialysis that we did for children in the hospital, which was quite exciting time for us to be able to at least manage a patient who had such a serious condition. So I improvised using intravenous fluids as well as a makeshift PD catheter.
Once you got started in terms of the care of patients in nephrology, both for pediatrics and adults, how did you end up getting to rheumatology?
Okay, so basically, after completing my adult nephrology training, I came back to Tanzania, and I worked for 3 years. And I noted that my skills and competence in caring for children was kind of limited, because what I was doing, it was just an extrapolation from adult nephrology to pediatric nephrology. Of course, on many levels could be similar in the approaches, but when you look at the congenital abnormalities and things that happen during birth and infancy and neonatal time, it was a little bit challenging. So I applied to go for training, and I went to South Africa for pediatric nephrology training for 1 year. I was fortunate that I got a fellowship. This was a joint fellowship. Pediatric rheumatology and pediatric nephrology was working jointly. So that gave me an exposure to see patients with rheumatic conditions. And that's where I applied for pediatric rheumatology training. It is an online training, and it is a 1 year program, but with a possibility of extending it. So I started that training program in 2015 when I was still in South Africa, and I completed in 2017 this training in pediatric rheumatology. So I came back home and finished the training while I was back home. So that's how I got into pediatric rheumatology.
Oh, wow. I love the fact that your attention is always peaked on connections and, how else you can be able to be more helpful to patients. Because I can't imagine while I'm doing one fellowship, I start applying for another fellowship to be able to help the population. And so now you also managed to finish rheumatology. And so, what did that mean for you going back home? Were you also running a rheumatology clinic when you went back home?
Yeah. So, and basically, I would also say that before going for pediatric nephrology training, I used to receive patients with systemic lupus erythematosus, and they were sent to me, at times referred to me. And being a nephrologist at that particular time, because I'd trained in adult nephrology, I knew how to treat them if they had lupus nephritis, but I wouldn't know what to treat if they have CNS lupus, and I wasn't really comfortable treating them in that way. And I felt sorry looking back that I had this patient coming to me. Yes, they had SLE, but they did not have renal manifestation. So I failed to treat them. And that's one thing that really gave me the push to train in pediatric rheumatology when I was in Cape Town. So when I came back, I continued with pediatric nephrology, and then I integrated patients with rheumatological condition in that clinic. So now we have a joint pediatric nephrology rheumatology clinic.
Roughly for the rheumatology nephrology clinic, how many patients roughly do you now see per clinic?
So in a clinic, we could see between 17, sometimes if it is a busy clinic, we might see up to between 15 and 20 patients in one clinic.
In one
Yes.
clinic. Oh,
yes.
And it's so amazing that, this combination really, and we're talking about 15 to 20, both pediatrics and adults, or do they have two separate days for clinic?
So I usually run the pediatric rheumatology and nephrology clinic on Tuesday, and this is supposed to be pediatric patients, but sometimes you also see some adults walking in. Now, I also need to confess that because of the shortages of rheumatologists in the country, I also see adults with rheumatic conditions. I can't refuse them, so they are always walking in. But the clinic is dedicated for pediatric rheumatology and nephrology, and usually running on Tuesdays in the morning.
How many, just out of curiosity, how many rheumatologists are there in Tanzania?
Oh, there are 2 adult rheumatologists in Tanzania now.
And 1 pediatric rheumatologist, which is yourself.
Yes, I would say so. Yes, I would say so.
Which brings me to another question. And I know we had talked about this a little bit before. What are your thoughts for people going into fellowship training, especially on the African continent? We're in a resource limited setting, and now more and more people are going into this subspecialist training. What's an important thing to be thinking about when you're going into these trainings and you know you're coming back to a resource limited setting, or you might be the only one taking care of very, very, very many people? You might be the only one or one of, a few less than five.
Yeah. So before I go to that, I also
Mm-hmm.
want to say that
Yeah.
because of the challenges that I've been facing and seeing adult patients that are coming my way,
Mm-hmm.
I've had to re-enroll to a general rheumatology course. But then
Mm-hmm.
I've been having challenges with that training. It's supposed to be a 2 years program,
Yes.
and with an extension of 1 year. So I've been doing that for the past 5 years. Unfortunately, I've not been able to complete it because
Mm-hmm.
I happen to have a lot in my plate, but I'm
Yeah.
still trying to make sure that I complete that training. So when it comes to doctors and healthcare providers from resource limited setting, when they're going for training, the first thing that I would say will be important for them to consider is if it is possible to pick a training center that kind of mirrors, which reflects their level of setting and the setting of care. That is very, very important because you will be able to work with limited resource. But people will say that you might not get exposure to everything that is done in the world. I completely agree with that. But it doesn't matter how much exposure you get. If these things are not established in your country, you're not going to use them. That's the first thing that I would like to look at when you're going
Yes.
for training.
Yeah.
Mhm. But if it happens, you get an opportunity to go in a state of art setting, and that is in the Western world. It is not a bad thing. It is a good thing that you're getting exposure in the best setting that you have.
Mm-hmm.
But in your training, I think it is important because oftentimes we don't think about the resources. If you're working for example, if you're working in Australia, you're working in UK, you're working in Canada, you wouldn't really ask yourself, will my patients be able to pay? Will I have supplies for these patients? So for example, if you're doing nephrology, you have always you have catheters available. You have always peritoneal dialysis fluid available. But you also need to think, how am I going to mobilize resource when I go back? Because you cannot expect somebody to do that for you. People are new, they do not know what you need, and really need to make sure that you educate them. For us to do these services, we need these services. So your task is not only to provide services, but to mobilize the resources that you can use to provide services. And these resources are not only equipment and supplies. No, it is also human resource. You might need to train. You might need to train your nurses. You might need to train colleagues so that they can support you in giving that services. So that's an important aspect that people that are training for subspecialty and they're going to be pioneers to bear in mind.
And I think that's so important. It's just interesting that when we're going for some of this training, and I remember having a conversation with one of our program directors, was just preparing the international graduate for going back to their country is not always, at the forefront of their minds. And like you're saying, how are we going to create, or how are we going to improvise with certain equipment that we don't have? Or dialysis fluid, if we don't have it, how are we going to reconstitute it? And it's so important for many of the international graduates to preempt, like ask your programs, look, this is the setting that I'm going back to. Please help me think through how I can improvise with various things, because you're the person who's going to be the point person or the lead person. And I think, Francis, it's so important that you mentioned that and, walked us through a very interesting journey in terms of fellowship from the academic standpoint. Looking at both your pediatric nephrology and rheumatology, what would you say were the highs of your training? Like, what was the most exciting times of your training for both of these fellowships?
Yeah, so first of all, I had a very nice training in my pediatric nephrology training. And one of the reasons is the fact that I went into pediatric nephrology training while I've been trained in adult nephrology. So it was like it's things that I've been doing, only that I was doing them in adults. So it wasn't like difficult. But I believe that I had a very good team. And of course, My personality also helped, because even when they were not happy with me, or if there are things that other people might find them offensive, I usually had a way of saying, well, after all, I'm here to train. So these are things that might distract me. I should not really focus on them. But then you should also know that I remember at one time during my training, one of my consultants asked me, we have a patient who is in a very quite distant place. They don't have supplies. Can you tell us how would you make a PD fluid if you don't have commercially available PD fluid? Then I realized that, okay, so we are asking our training directors to help us to go back to, to our setting. But these people do not know
They also don't
what
know.
they also do not know. So they might not be in a position to prepare you. It's like
Yeah.
these people are using, I mean, the facilities that they're using are completely different, and they do not know your setting. So you're supposed to be
Mhm.
the expert of your setting and your environment and your people.
Right.
So they can only train you in the specialty that you want, in the principles of care and what you need, but
Yeah.
not how you navigate through and setting up new programs in your country and making
Hmm.
sure that whatever you're trained on is getting integrated into the care. Because you should also remember that there are conflicting priorities
Oh,
when
that's
you go back.
when you go back. Oh my gosh. Like that's right. Now the student becomes the teacher because now you're teaching them from your context. Oh my gosh, Francis. And if you think back, what were some of the lows for you during this training experiences that you had?
Um, so I think one of the challenges that I had is, at one time when I was in Norway, the setting dictates how much you can do. So if you look at the what the nephrologist does in Norway and what the nephrologist does in Tanzania, they are two completely different things. Because in Norway, the dialysis access are being put by intensivists. These are the ones that are doing that. And the renal biopsy is done by only one person. So you don't need to have to train everybody to do biopsy. So if you're looking at the level of what one nephrologist does in Norway is completely different from what they do here. So at one time I was sitting there and saying, okay, now I don't think I'm getting enough exposure here, because when I go back, I'm expected to do all these things on my own, but I can't see myself doing all these things here. And of course, one of the things that I trained in when I was in Norway is the fact that I spent quite some time in the dialysis unit. And in the dialysis unit, I was working with the nurses, these are dialysis nurses, and they were really excellent. They did not need any doctors that were coming there, and the doctors would only come once in a blue moon if there's something that is really pressing. So you could imagine I spent almost a month in a dialysis unit with only nurses, no doctors was coming there. So they trained me in everything that I knew about dialysis. And these are the nurses. So if you look at the scope of care and what the nephrologist does in Norway and other Western countries, it's completely different. So that was something that got me scared at some point. But when I went to India again, I was able to see everything that was happening, and I had enough exposure in terms of what we are expected to do back home.
While all this was happening, you are a family person. What was happening in the background, from a family perspective as you were pursuing all this, academia?
Yes, so this is the other drawback of training outside the country. So I had to spend almost a year outside the country, and I had to leave my family behind. I had my wife and my young child at that time. So, and my child was when I started training, my child was 3 years old. So I had to be outside the country for that time, because I had to spend 6 months in Norway and 6 months in India during the 2 years of training. And then again, when I went for pediatric nephrology training, I had to spend almost a year outside the country for pediatric nephrology training. So that can also be challenging. And I think that's one of the limiting factors for most of the healthcare providers from this end to pursue training outside the country, because it is not only the new setting that you have to face, but you also have to leave your family behind, which is
Yeah,
quite difficult. And even if you want to move with your family, sometimes you might not have enough facilities to support,
yeah,
the schools, the accommodation, all these things could be
yeah.
quite difficult to organize for you to move with your family. And it
Hmm.
is a short time again. If you're interrupting school for 2 years or 1 year, and then when you come back, you have to again reintegrate your your children in school. That could also
Mm-hmm.
be difficult. Yeah.
That could also be really, really tough. And a big shout out to your wife for having been so supportive and being able to take care of your child while you are, studying and out of the country. And you told me something really interesting while you were in South Africa. What was happening in the background from a family perspective while you were away studying?
Yeah, so when I was studying, my wife was pregnant, and we got many babies delivered and she found out that she was pregnant when I was away. So that was also quite scary. But I thank God that it turned out to be fine. She delivered 4 babies, and they're all doing very well. And I had to come back and interrupt my training for almost 2 months, and then to help her, and then I went back to complete my training.
Oh my
Yes.
gosh, your wife is amazing. She gave birth to quadruplets while you were on fellowship. And I like when you told me this, I was like, oh my gosh, this is a superwoman. And so big shout out to both of you because also as a parent, I can't imagine getting the news that I'm expecting 4 babies. My spouse is out of town, not out of town, is in another country. And then even for you as a father, being able to, hear that news and you're still at school and having to pursue that. What's the advice you'd give a parent or a father out there who's doing their fellowship and their wife is having to raise young children or is expectant? What was the one thing that helped you balance those two things? So on the one hand there's the fellowship, and on the other hand there's your pregnant wife or very young child and wife back home. What would be the an encouragement to this person, especially for men out there who are pursuing their studies?
Well, so I'm not sure if it might not be easy, but always I believe that sometimes there are sacrifices and compromises that are being made. I look at it as maybe this is just a short time, but then there's a bigger goal that you have to achieve. And I believe that what I was doing is the just cause and is a bigger cause, being able to help children and people in the country. So I looked at it as one way that you're giving away to help others. It can be quite difficult. I can't really say what it means to the spouses that are remaining behind. And it is not only men. I remember that during my adult nephrology training in Norway and India, I had a colleague who also had to leave have small baby, 2 years old baby to pursue the training. So, and that can be quite difficult. I mean, if you're comparing between men and female, leaving behind a small child. But I guess you just need to have faith, and you also need to have an understanding spouse, but also having a family support structure that can assist. That is also very, very useful because you need to get everybody helping.
No, that's really, really helpful to hear that. And when you think about things from the mental health perspective, what were some of the things that helped you maintain your mental health and helped you, stay grounded during the time of your studies?
Yeah, so basically, I would sit down and watch movies, and sometimes when I was really tired, I would take a long walk. So I would walk a long, long time, and that that gave me time to reflect and to refresh because you're walking and taking a long stroll. That was really useful for me doing that. But also having friends was really good. Having friends, and particularly having friends from your setting. And I would like to say that Dr. Ombeva was a colleague that sometimes we would sit down and chat, and go to church with Dr. Ombeva, who is an infectious disease specialist from
Yes,
Kenya and Uganda.
yes, I know Dr. Mbeva. Oh, well,
So
not
I
personally,
was,
but I know of Dr.
yeah.
Mbeva. That's amazing.
Yeah, so Dr. Mbeva, I was with Dr. Mbeva in South Africa. So having friends like that, it was really useful. And there's also another colleague from Zambia, Dr. Chisambo. She's a pediatric nephrologist. She was doing pediatric nephrology training in Cape Town at that time. So having these people around was really helpful because you could talk, we could chat, you could relax in a way, talk something else and reflect what is it that you're missing from home. At least we are not coming from the same country, but at least we could discuss and talk about our setting, which is in a way similar. So we would always sit and chat and talk about other things apart from just the difficult times that we had during our training, because I can assure you that it was also difficult because you're competing with colleagues who are working there, and sometimes they will do things that you might we are all learning, so you are also competing for opportunities to put in access competitions. So my colleagues were also competing to get an opportunity to put in a angiogram catheter, and this competition with colleagues, the local trainees. So everybody is making sure that they grab the opportunity to do these procedures because we are all learning. So that at times could be challenging.
Oh, wow. It's so amazing to hear that you got to get friends on the African continent who are able to support you in the way that they did. And we're giving them their flowers today. And we really appreciate all the support that they were able to give you during this time. And I'd like to believe continue to support you even now as you are a professor in the university and also continuing with your medical practice. In terms of, the overall experience, do you have any regrets about your learning experience in fellowship?
Not really. I really do not have any regrets, and I think if I'm given an opportunity to redo it again, I would have done. I will do it the same way.
Okay, that's amazing to
I
hear.
just do it the same way.
Yeah, you
Yeah,
just do it the same way. That's great to
sure.
hear, Francis. And when you think about a word of advice for someone who's thinking about fellowship, someone who's trying to figure out how am I going to do this thing? There are all these things that I have to consider. What would be your words of advice for someone thinking about a fellowship?
Yeah. So first of all, is I think people really need to do something that they love. That's the first thing, because passion is everything. You should do something that you're passionate about, and I understand that a lot of people really want to do some. I mean, colleagues, most of the colleagues now are asking what is the most paying subspecialty, and what subspecialty can give me job immediately. I don't think these are the aspects that should be considered when somebody is going for fellowship. Just do something that you like and that you're passionate about, and you will be able to make something out of it. Passion will always make you do something out of your training, and it's usually not that difficult. It is difficult, but once you get through the process, you are learning how to cope with the challenges that are coming, and so you don't need to be scared. I mean, the best thing, if you really want to learn how to swim, you have to go into the water and then you swim. That's how you do things.
That's such great advice. I love the fact that if the only way to learn how to swim is you need to get into the water. You need to just dive in and start. So I just want to take time and say a very big thank you to you, Francis, for taking time this morning out of your busy schedule to share your experiences with us and also what your journey has been like. And I'd like to believe that there'll be young colleagues and even peers who will listen to your experience and be encouraged about the journey of medical education and subspecialty. So I really appreciate you for that. Is there a way that people can be able to reach you should they have, any questions about fellowship, any questions about any collaborative work in nephrology and rheumatology in Tanzania? Is there a way they can reach you, an email or a social media handle that you would be able to share?
Yeah, indeed. I believe they can always reach at me, and I'm usually present on Twitter. My Twitter handle is Furia underscore Francis, and I guess my threads handle is also Furia underscore Francis. And people can reach to me through that, and they can ask questions through Twitter. And I believe that's the best way, because if they ask questions, other people can also learn from the questions that they're asking. I'm also on LinkedIn. So they can reach me through these social media accounts. That would be the best and easier way of reaching out to me. And I use Twitter a lot, and I use that for health education to the community. At
Mm.
times educating the community and sharing health-related information with colleagues and community.
Oh, wow, through Twitter. That's amazing.
Yeah,
And
yeah.
in terms of the kind of reach that you have, how successful has been your sharing of messages? through Twitter?
Well, on Twitter, I have 17,000 followers on Twitter, and that's I wouldn't say that that's the biggest because I know people have millions of followers, and
Mm-hmm.
but that's quite huge. But I also work with other networks which are widening the reach of what I do.
Mm-hmm.
So I would
Mm-hmm.
say that working with other people that have a lot of followers helps a lot. And I also
Yeah.
do Clubhouse.
Yeah.
Clubhouse is another social media app, voice app, which we discuss things, and we use that a lot during COVID era to educate the community regarding COVID and what people need to do. So it
Mm-hmm.
was quite an interesting experience because Clubhouse was launched in the COVID era.
Oh, wow. No, this is amazing. And I feel like we might need to invite you again to the fellowship safaris to talk about how to get, education out there, because I think for a lot of us as subspecialists, you want to be able to share more information. And so we'll be definitely reaching out again to be able to talk to you about the kind of outreach you've been able to do. So thank you once again, Francis. I really appreciate you and appreciate your time. And, for those who are listening to this episode, we look forward to hearing from you and what you have to say through our website, through all social media platforms and all podcast platforms. And so until next time, bye. I'm so glad you stayed tuned. Please get the word out and share it with at least 3 people. Make this episode like a chain letter. Share it, share it, share it. Come back for the next leg of our safari where we'll be talking about...
It's usually a journey and it gets better. It's a life journey. You'll go do internship, finish, become a medical officer. You might want to pursue the medical side. You might want to pursue the non-medical side. All of it is okay.
Mm-hmm.
You just follow where you think your sense of duty is.
Yeah.
Not really passion, but your sense of duty.
Your sense of duty. I love it, where your sense of duty is. Listeners are advised to use their own judgment and discretion when applying any information discussed in this and all podcast episodes to their specific situation. Always seek the advice of a qualified professional if you have any concerns or questions regarding a particular subject matter. You can find this and other episodes of this podcast on our website at www.fellowshipsafaris.org. You can also find all our episodes on all podcast platforms. Reach out to us on social media as Fellowship Safaris on Facebook, Instagram, and TikTok, and our Twitter handle is @fellowshipsafar. You could also send us an email on fellowshipsafaris@gmail.com. We look forward to hearing from you and interacting with what you have to say about the Fellowship Safaris podcast. It takes a village to make this podcast. The executive producer and original music is done by Mokavi Maweu. The sound engineer is Tevin Sudi with thanks to AQ Studios. Graphic design was done by Benjamin Mboya. We would like to give a special shout out to Josephine Karianjahe and Melissa Mbogwa of Africa Podfest. All rights reserved by Dr. Njeri Karianjahe and the Fellowship Safaris podcast.